بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, this lecture is about the intensive care radiology with particular emphasis on the role of examination of the chest by different modalities in the ICU patients. The topic will be handled on two parts. The first part will deal with the equipment and how to judge every line and every tube and its accurate location and what are the possible complications of each of them. And the second part will deal with the pulmonary, mediastinal, and pleural lesions that can be seen in the ICU patients. And you know that we have three important imaging modalities for evaluation of the ICU patients, and these are the X-rays, ultrasound, and the CT scan. Of course, the X-ray can be portable and can reach the patient in the ICU, and also ultrasound is the same, can be moved to the patient. While CT is now available in a portable fashion, but usually it needs in space in the ICU and certain facilities to do a CT scan. But I will explain the importance of CT in some conditions where you can move the patient to the CT unit, or if the portable CT is available and you can use it. Then we have the major items here. Number one, we should evaluate the tubes and line, and these are the endotracheal tube, the tracheostomy tube, intercostal tube, nasogastric tube, central venous line, Swan-Ganz catheter, pulmonary artery catheter, and cardiac pacemaker. Then in the second part, we'll discuss the possible pulmonary parenchymal lesions, including atelectasis, aspiration, pneumonia, pulmonary edema, acute respiratory distress syndrome, barotrauma, and the lung abscess. Then we'll have some talks about the pleural pathology, including effusion, pneumothorax, and hemothorax. And also we'll have some words about the mediastinal pathology, including non-mediastinal pulmonary embolism, superior vena cava thrombosis, aortic dissection, and cardiac tamponade. Then portable X-ray is one of the valuable tools in evaluation of ICU patients. But there are some limitations for this modality, which is the modality for imaging of the chest in these patients. The limitations include the space constraints, the limited power of the portable X-ray machine, the long exposure time, and the chest radiograph is usually obtained in the supine or the semi-erect position, which may limit the inspiration of the patient, and this will affect the quality of the radiograph. Also, we may have undesired lordotic projection depending on the patient position. The patient in many times cannot have adequate inspiration, and this will lead to elevation of the diaphragm and they give a false impression about the cardiac size. Then inadequate visualization of the lung apex and the costophrenic angle sometimes is seen in these portable X-rays. This is an example of an expiratory film where the diaphragm is not descending down to the 10th rib posteriorly, and this will result in flattening of the cardiac shadow and some broadening of the mediastinal borders. And this is another example to compare between the expiratory and the inspiratory film. Here you can see the diaphragm is reaching the sixth rib posteriorly, but if the patient had adequate inspiration, the diaphragm will descend down to the 10th rib posteriorly. This is the difference between expiratory or inadequate inspiration and adequate inspiration. You see the elevation of the diaphragm, the flattening of the cardiac shadow, and the broadening of the mediastinal borders. Also, it is not possible to judge the quality of the radiograph in the ICU patients, and many times we may have an under-penetrated or soft exposure or an over-penetrated or hard exposure, and this is the optimal exposure as you can see here. But uh, we may face these two exposures during our interpretation. Then many of the patients are not well centralized during the X-ray examination, and this will result in inadequate visualization of the lungs in a symmetrical way and may give a false impression about some enlargement of the hilar shadow or some translucency of one of the lungs compared to the other. And if you want to judge the adequate position of the patient, you just identify the spinous process of the dorsal vertebrae. Then you measure the distance of the clavicle on the left side and on the right side. If they are equal, then the position is good. If they are not, then the patient is tilted to some direction. And this tilt may be or rotation may be so severe, as you can see here. There is a big difference between the distance on the left side and the distance on the right side. This will result in displacement or apparent displacement of the cardiac shadow to one side and false impression that there is enlargement of the hilar shadow or possible mass in the hilar shadow. Then the patient position will also affect the radiographic projection. Sometimes you are not able to elevate the patient neck so that it will not cover part of the apex of the lung, and there may be also some tilt of the X-ray tube, inevitable tilted, so that the projection is not the optimal one. In this particular patient, they see that the nasogastric tube has been introduced into the trachea, reaching the right main bronchus into the lower lobe bronchus, and reaching the pleural space. This is one of the complications of the nasogastric tube that I will mention also. Then here you can see that the chest X-ray is not that good because you are not able to see this costophrenic angle. You can see the apices of the lung, but this patient had pneumothorax and has the sign which is known as the deep sulcus sign. You should see the costophrenic angle till its end, then you are able to diagnose this particular disease. Ultrasound is one of the best diagnostic modalities for the ICU patients because ultrasound has many advantages. It is a fast examination. It needs no preparation in most of the times. It is very sensitive. It is non-invasive. There is no radiation exposure. It is a portable machine. It has the facility of real-time imaging, and it has the Doppler facility, which enables you to see the arteries and veins. Also, ultrasound can be very valuable in guidance, the insertion of the devices, especially the central venous line and the pulmonary artery catheter and so on. Also, ultrasound is very helpful in localizing the tubes and lines, inserted through the patient's chest. Detection the device related complications. Ultrasound is a very good machine to see pulmonary parenchymal lesions, pleural pathology, mediastinal abnormalities, especially if the one who is handling the probe is eminent. Then you need a professional sonographer to see all what I have mentioned in the chest abnormalities. Then evaluation of the myocardial perforation, hemopericardium, pericardial effusion is can be achieved easily by echocardiography and by simple ultrasound. Detection of the thrombosed vessels, especially the subclavian and the internal jugular vein. Then the risk and the cost of transporting patient from the ICU to the CT scanner and back to the ICU unit. This will limit the value of CT in ICU patients. But now you know very good that there are a lot of portable machines that can be used in the intensive care unit, and I will try to show you one of these machines
This video is
that
intended to
are
demonstrate the ease of use and portability of the Ceratom Portable Multi-Slice CT Scanner in the ICU scenario. The Ceratom is developed and manufactured by Neurologica Corporation of Danvers, Massachusetts. You have a patient that requires a neurological CT scan in the ICU unit. Retrieve the Ceratom and workstation from the assigned storage location. Proceed into the patient's room to survey the room layout and position and head of the patient's bed. Check the floor for any obstructions. Remove the headboard from the patient's bed frame. In order for the scanner to be positioned successfully in the patient's room, a total of 4 feet should be available between the head of the bed and the wall. If necessary, the bed should be moved or rotated to allow for this distance. Position the scanner at the head of the bed, leaving 3 feet between the device and the bed. This is important so the user has room to attach the scan board without hitting the front of the scanner. Mount the adapter on the headboard mounting pins. Secure the scan board to the adapter while simultaneously pressing down on the scan board onto the mattress and tighten the handle. Preparation and positioning of the patient for Ceratom CT scan. With at least one person on each side, slide the patient onto the scan board. Larger patients or vented patients may require an additional assistant to help guide the patient's head during the move. Immobilize the patient's head with a head strap. Securing the patient's head is one of the most important steps during the patient setup. Once the patient is secure, lower the scanner onto the centipedes, making sure that the scanner is as perpendicular to the patient as possible. Unlock the bed and slowly move the patient into the gantry until the shoulders of the patient touch the outside covers. Verify the patient's starting position by turning on the laser lights. The patient's head should be centered with the gantry, with a minimum of 2 fingers between the bottom of the scan board and the collimator covers. Scan time. At the LCD screen, choose Select Protocol. Choose the preferred protocol, then choose Accept Protocol. Prepare the scan. Start the countdown for the scan to begin. Exit the room or stand at least 12 feet from the scanner. While the X-ray is being generated, images are sent wireless to the workstation for viewing. Proceed to the patient's bedside. Choose End Exam on the LCD screen. Completion of the scan. With the assistance of the nurse, slide the patient off the scan board onto the bed. Remove the head strap from the patient. Then remove the scan board and mounting adapter from the patient's bed. Return these items to the storage slot and pegs located on the back of the scanner. Raise the scanner using the lift button on the side of the scanner. Remove the scanner from the patient's room. Return the scanner and workstation to the storage location. Plug the Ceratom in to charge when not in use.
Okay, and you know that this machine is designed for neurological studies, especially for the brain, but there are nowadays larger machines that can fit for the chest and the abdominal exams. And the CT is very important in evaluation of the ICU patients, especially under certain indications about you can see here about 25 to 75% of ICU chest CT scan shows clinically useful information. Sometimes small pneumothorax and changes in the lung parenchyma. Also, the position of some of the tubes can be verified accurately by the use of CT scan. The change in the measurement was reported in about up to 40% of the scanned cases. The values of the CT scan include some of the pleural diseases, the detection of small pleural effusion, the differentiation between effusion and emphysema based on the contrast enhancement. Also, the detection of hemothorax, for example, and in cases of pulmonary disease, the detection of pneumonia or unsuspected small tumor that cannot be seen on the plain film. And CT also is superior in detecting cavities in the lung and differentiation between abscesses and emphysema. Then, in cases of the devices, CT has revealed the chest tube malposition in about 15% of the cases, and they detect the complications of mechanical ventilation about 40% of pneumothorax, 70% of emphysematous bully, 80% of pneumomediastinum that were not seen on the chest x-rays. Then unsuspected pneumothorax was found in about 7% of the ventilated patients by CT. And of course, you know that CT is the primary imaging modality for diagnosis and confirmation of the diagnosis of pulmonary embolism. Now we'll have these tubes and we will emphasize the accurate position and the complications of each tube. I will try to show a small video about each of these tubes, how it can be inserted, and how can we judge the accurate position of the tube. We'll start first by the endotracheal tube. And this endotracheal tube, as you can see here, is used to maintain the airway and to provide ventilation and in patients with hypoventilation or hypoxemia. The endotracheal tube should be positioned in the middle part of the trachea, and the accurate location should be about 5 centimeters above the level of the carina, putting into consideration that if the patient flexes his neck, the tube will descend for 2 centimeters. And if he extended his neck, the tube will ascend for about 2 centimeters. Then this is one of the videos that can show you how to insert the endotracheal tube.
We want to make sure that we have a tube in the trachea with the cuff inflated. That's the definition of a secure airway. As you prepare, you want to make sure all your equipment is ready to go. The laryngoscope is powered, bulb is working, endotracheal tube with a stylet in place. The tip of the stylet, of course, recessed from the end of the tube. Inflate your cuff to make sure that it's working. Suction is available as well. Normally, your resuscitation team would be bagging the patient. When you're prepared, the guideline is for the provider to take a deep breath and hold it just as your patient will be holding the breath as you prepare to do your intubation. With the head slightly tilted, making sure that suction is applied so all the secretions are out of the way. The laryngoscope blade is introduced, the tongue is swept to the right, and the elevation on the laryngoscope blade goes up and away from the patient, not cranking on the teeth. Visualizing the cords, I place the tube and watch the cuff go inside the cords. Stylet comes out, cuff is inflated, and patient is ventilated. Watch for rise and fall of the chest, and then auscultate to hear breath sounds on each side with no borborygmi. An additional device is the end-tidal CO2 monitor. Once the patient has been intubated successfully, this device allows you to double check and make sure that you're in the trachea. By placing this device between the endotracheal tube and your bag, you're able to watch for a color change that occurs that witnesses the CO2 level rising with your resuscitation. Normally the color is purple when it comes out of the bag, showing low CO2 concentrations, and you expect to see this change from purple to tan to yellow, letting you know that you have successful intubation.
And this is the demonstration how the endotracheal tube is inserted, and you inflated the balloon not too much, but to keep the tube in position. Then you fix the tube in appropriate position, which should be about 5 centimeter to this proximal to the carine. Then the complications include malposition, and malposition, either the tube is too high or too low, or it goes by mistake into the esophagus. Then if you overinflate the balloon, this may lead to tracheal rupture or may put some pressure on the tracheal rings, leading to tracheomalacia. Complications of ventilation include interstitial edema, pneumothorax, and pneumomediastinum. And sometimes you got aspiration pneumonia, nosocomial infection, and intratracheal clots or mucus plug. Then over distension of the endotracheal tube balloon may have the previously mentioned complications. Then also if the balloon to tip distance is less than 1.3 centimeter, then the normal balloon to tip distance is about 2.5 centimeter. This is one of the undesired tubes, but this is a good tube. And tracheal rupture usually involves the membranous part of the posterior wall within 7 centimeter from the carina. If the trachea is ruptured, it may lead to subcutaneous emphysema, pneumomediastinum, and pneumothorax. And if you look carefully here, one of the difficult situations of interpretation of the chest X-rays in the ICU patients is the presence of too many devices, leads, and tubes. Then you have to verify each tube and line separately in order to judge its accurate position and the possible complications. Then if you look carefully here, and these are the ECG leads, then you see the endotracheal tube, and this is the balloon which is overinflated, and the tip of the balloon is going too much into the right main stem bronchus. One of the best ways for judgment of subtle pneumomediastinum is to look to the patient neck. If you can see streaks of air in the patient neck on one side or in both sides, then you may feel that there is pneumomediastinum. One of the complications also is to put the endotracheal tube into the esophagus, and this esophageal This esophageal intubation is very dangerous, of course, because air will enter into the esophagus and will distend the stomach. And if you look to the chest X-ray, you can see the endotracheal tube is not passing in the airline of the trachea. It goes a little bit towards the right side where the course of the esophagus. Then, if the tip of the endotracheal tube is too close to the carina, this may lead to selective bronchial intubation, especially if the patient flexes his neck. This tube will go into the right mainstem bronchus. And this is selective bronchial intubation. You see the endotracheal tube, which is this is the tracheal bifurcation, and the endotracheal tube where is passed into the right main bronchus, resulting in hypoventilation of the left lung. And this film is frequently seen in ICU patients where you can see the endotracheal tube is selectively in the right mainstem bronchus and with resultant complete collapse and whitening of the left hemithorax. Then one of the good possibilities when are you interpreting the chest x-rays of an ICU patient and you got this appearance, there is almost total consolidation or whitening of one of the hemithorax, then look to the position of the endotracheal tube. This is one of the commonest causes of this appearance. At that time, you will see that the tube is going selectively, usually to the right main bronchus. Then nowadays we have the double lumen endotracheal tubes where you can selectively insert one tube into one of the main bronchi and the other tube end will be in the trachea. This will help to preferentially ventilate one lung. If you want to ventilate the left lung, put one of the tubes into the left main bronchus, the other tube will be in the trachea. Then to avoid spillage or contamination from one lung to another, if there is infection in one lung, especially in cases of TB, for example, then to allow unilateral bronchopulmonary lavage if you want to have samples from the bronchial lavage from one lung, not from both lungs, then to control the distribution of ventilation of each lung. And this is an example of double lumen endotracheal tube. If you look here, and you can see that the endotracheal tube is passing to the left main stem bronchus, but both lungs are adequately aerated. These are surgical drains. Then if you look in this magnified image, and you can see that this is a double lumen endotracheal tube. One of the lumens is in the trachea and the other is selectively into the left main bronchus. Then we came to the tracheostomy tube, and these tubes are placed when long intubation is required. The tip of the tube is located about half away or two-thirds from the distance from the stoma to the level of the carene. This tube is not changed by extension or flexion of the patient neck. If you insert a tracheostomy tube, you expect some subcutaneous emphysema and pneumomediastinum. Surgical emphysema, if it is progressing or very large, then you consider complications. I will mention these complications. And one of the complications of tracheostomy tube is the initiation of granulation tissue and fibrosis, especially in long-standing cases that will result into tracheal stenosis. This film will show the types of the tracheostomy tubes and how can these tubes be.
Each different type of tracheostomy tube tends to be designed to perform a specific function. Tubes come in different shapes and sizes, and that's mainly because different patients have different sized tracheas. Some tracheostomy tubes also come in different lengths. Some patients will have a greater amount of tissue on the outside of the trachea, so it's important to have tubes that allow for that. Cuffless tube is useful because it allows some airflow through the upper airway. It's also a simple tube. It's safer. If it becomes obstructed, the patient can potentially breathe through their normal upper airway. Cuff tube has a balloon which we can inflate, and that allows us to ventilate patients down it without all the air leaking out around the outside of the tube. It can also be useful in reducing aspiration of oral contents, potentially when somebody's swallow isn't as great as we'd like it to be. We have inner cannulas in tracheostomy tubes to try and prevent complete tracheostomy obstruction. If we can just change the inner cannula regularly, that saves us having to change the whole tube in an emergency. So some tubes have special functions. One of these would be subglottic suction, which is an additional port which allows us to aspirate some of the secretions that can build up above the cuff and potentially cause pneumonia. Another one would be fenestrations in the top of the tube, which can allow extra airflow through and improve a patient's speech.
Okay, then this is the endotracheal the tracheostomy tube, and the patient also had a central venous line. We'll discuss in this lecture. And also, if you look carefully, you can see a stent within the superior vena cava, which is usually used to treat the superior vena caval thrombosis, which is one of the common complications of multiple central venous line insertions. Frequently, there is some fracture of the tracheostomy tube, and part will be inhaled, and especially will go to the main stem, the right side bronchus. Also, the part of the inner tube may slip and go within one of the bronchi. And this patient had this slippage for 1 year duration, and is not complaining of significant symptoms. This is also one of the dislocation or slippage of the inner tube into the left main stem bronchus. Then we came to the chest tube or the thoracotomy tube, which is a common procedure in the ICU patients used to evacuate pleural air or pleural fluid. One of the important things is to introduce the tube over the superior margin of the rib to avoid, of course, the intercostal nerve and intercostal artery, which pass below the inferior edge of the rib. The position of the chest tube depends on whether air or fluid is being removed. If air, the tube is directed upwards. If fluid, the tube is directed to the side of the fluid accumulation. Most of the tubes have side holes, and also they have in a line which is radio opaque to identify the tube itself and also to allow identification of the holes. And this video will show you how to insert the intercostal tube.
If possible, it is helpful to have an assistant scrub in to help maintain sterility and control the wire. Prepare the skin with appropriate cleansing solution per guidelines. Select the location for the chest drain, usually the 5th intercostal space at the anterior axillary line. Insert the needle just above the rib into the pleural space. It should be advanced no more than 1 centimeter. Note, you may also attach a syringe to the needle and aspirate while inserting to confirm placement. Pass the wire through the needle as far as the mark on the wire.
Just to hold the end of the guidewire. Yeah, please.
Stabilize the wire with one hand and remove the needle with the other. It is important to hold the wire in place and still at all times.
Can you give me the dilator? Look, yeah, the smaller one. Yes, read it for me.
Pass the first dilator along the wire, through the skin about 1 centimeter, angling anteriorly, then remove the dilator. The skin may require a small incision. It is important that the wire is held still at all times and not advanced or withdrawn.
We are dilating. Okay. Then we remove it. Bring the, no? Yeah, bigger size.
Pass the larger dilator along the wire, through the skin about 1 centimeter, angling anteriorly, and then remove.
Okay. So can you grab this chest tube, yeah? Yeah. No.
Insert the chest tube over the wire and into the infant just until the holes on the chest tube are inside the infant.
No, no, continuous cap. Yeah, you just read it. So we have holes here.
Yeah, I see them.
Yeah, so they marking after the holes. Okay, so this is full term baby, so we be sure that the hole marks inside. Then 1, 2, 3.
Okay.
So we are 3, and even if it passed to you, it is here 5. So this is here 5. So this is 4. This is 3. Yeah.
Okay, perfect.
So.
While stabilizing the chest tube with one hand, remove the wire with the other.
Then I'm removing this one. And we need to connect now to the connection system. So please
The chest tube should now be attached to either a chest drainage collection system or Heimlich valve.
Okay. Now we will discuss the complications of the tube, and the first is, of course, the malposition. And how can you judge that the tube is malpositioned if it fails to drain air or fluid? Then the incomplete insertion of the tube may result in ineffective drainage of the pleural fluid or the air. Then accumulation of air or fluid in the chest wall may complicate incomplete insertion because the holes of the side holes of the tube may be some of them may be in the chest wall itself. And one of the possible complications is to put the tube in the extrapleural space, and this is not rare as written in the literature. And if you fail to visualize the opaque line on the tube, they may be one of the indications that the tube has an extrapleural location. Now look to this example of right-sided pneumothorax, and the chest tube has been inserted, but the follow-up X-ray showed no improvement of the pneumothorax. And the CT scan, and this is one of the advantages of CT in this particular case, showed that the tube is located outside the pleural space. It is in the extrapleural space running along the chest wall, and that's why there is no drainage of the air. But after correct position of the or correction of the position of the tube, and you can see the radio opaque line, you can see the holes, and you can see also that there has been adequate drainage of the pneumothorax. And if you look to this chest X-ray, you can see that the tube is draining this amount of pleural effusion. It looks in a good position, but the CT scan and this is sorry for this. And here you can see another example of the tube, which looks not accurately positioned into the pleural space, and there is a significant amount of surgical emphysema in the chest wall. The CT scan of this patient showed the presence of pneumothorax, and the tube is in the axilla with a significant amount of air in the chest wall. Then also one of the malpositions is to that the tube has passed into the commonly in the horizontal fissure and less commonly in the major fissure. And if you see a horizontal course or an oblique course, which may coincide with the course of the fissure, and this is an intrafissural position of the tube. If you suspect this, you can have the lateral view, or better, you can have the CT scan. Also, one of the malpositions is to put the tube inside the lung parenchyma, which will lead to lung laceration, hematoma, infarction, and sometimes a bronchopleural fistula. Uncommonly, you can pass the intercostal tube to the mediastinum with some possibilities of heart or great vessel injury, and less frequent or rare that the tube has been passed through the diaphragm, causing some laceration of the abdominal organs like the liver, spleen, and the stomach. This is an example of a tube in the fissure. And you see this course of the tube, which looks like an oblique course, but in the lateral view, it coincides exactly with the course of the fissure. Then if you have this horizontal course and the suspect intrafissural location of the tube, you can have the CT scan, which will show the position of the tube in the fissure. And also, if you suspect that the tube has penetrated through the lung parenchyma, as you can see here, CT scan is one of the best modalities. Also, ultrasound is good for demonstration of the intraparenchymal position of the tube. And this is another example. You see here the tube, and you see some consolidation with lung opacification, and the CT scan showed that the tube has been introduced inside the lung parenchyma. And this tube has been advanced until it reached the mediastinum and is located anterior to the heart in a retrosternal location. You can see this is the tube reaching the midline, and there is some air in the subcutaneous tissues. And also complications of the tube is kinking. If the tube is kinked, of course, you can expect inadequate drainage, or the tube is intermittently blocked due to the presence of blood clots or pus or debris inside the tube holes. Occlusion of the tube also if the tip is against the mediastinal border. The malposition of the tube will lead to inadequate drainage, may lead to herniation of the lung parenchyma into the lumen of the tube, causing pulmonary infarction. And you know that infarction is a lung opacity. We'll discuss this in details in the second part of this topic. Then injury to the intercostal vein or artery may lead to an extrapleural hematoma. This is an example of tube kinking, and you expect inadequate drainage. The hemithorax is still opaque. And this is also, sorry, this is also an example of tube kinking, and you can see extensive air in the subcutaneous tissues. One of the complications of the tube is known as re-expansion pulmonary edema. This will result from rapid removal of air or fluid from the pleural space. Then the rapid expansion of the underlying lung parenchyma will result in pulmonary edema. And the pathogenesis of this pulmonary edema is not actually completely known. There are theories including increased pulmonary vascular permeability, surfactant depletion, increased production of oxygen-free radicals. But in these patients, you can see adequate drainage of the fluid or air, then opacification of the lung parenchyma due to the presence of pulmonary edema. This is an example, and you can see there is pleural effusion on the right side, and over 2 liters were drained rapidly. There is adequate drainage, but the underlying lung parenchyma is now opaque, and this is known as re-expansion pulmonary edema. I will discuss also the different types of pulmonary edema in intensive care patients in the second part of this topic. And this is another example. You see a pleural effusion on the right side, and it has been drained, then followed by the appearance of pulmonary parenchymal opacity representing re-expansion edema, and the follow-up showed resolution of the edema. This is the CT scan of the same patient, showed the middle lobe opacification due to pulmonary edema. In this patient, there is collapse of the left lung with suspected pleural effusion, and the major cause was the endotracheal tube that has been selectively reaching the right mainstem bronchus. And after correction of the position of the endotracheal tube, and they also put an intercostal tube, which was not indicated in this particular patient, and can see some expansion of the adequate expansion of the lung with some opacification, denoting re-expansion pulmonary edema. And this is another example. You see a patient with large amount of pneumothorax on the right side. After drainage of the pneumothorax, there is opacification of the lung representing re-expansion edema that has been cleared out in about 7 days. Then we came to the fourth tube, which is the nasogastric tube, which is usually put into the stomach through the nose to have many values or indications. It helps for feeding or suction of gastric contents or administration of medication. And this is the way how can you insert the nasogastric tube.
You'll need 14 to 16 French gauge nasogastric tubing, water-soluble lubricant jelly, catheter tip syringe, a suction drainage system, and hypoallergenic tape. Also ready, a glass of water with a drinking straw, and within easy reach of the patient, a towel, tissues, and the emesis basin. Our patient is placed in high Fowler's position with shoulders well elevated. We gauge the length of tube to be inserted by measuring from the tip of the nose to the earlobe to the xiphoid process. Mark the length of tube to be inserted with a bit of tape. We can create a gentle curve in the pliable tubing by winding 4 to 6 inches of tube tightly around the index finger. Then lubricate the end of the tube to be inserted. 3 or 4 inches should do. Have the patient extend his neck back against the pillow and begin the insertion with that slight curve pointing down. Proceed slowly, guiding the tube along the floor of the nasal passage, aiming down toward the ear until you're just past the nasopharynx. At this stage, explain to the patient that he'll have to swallow to help the process along.
With the end of the tube now just above the oropharynx, have the patient flex his head forward, take a small sip, and swallow. You'll advance the tube by an inch or two with each swallow. The patient may cough or gag if the tubing has accidentally entered the larynx. You can pause, withdraw slightly, and ease the patient with a sip of water. Be careful, there is a risk of aspiration. Advance to the measured mark and anchor the tube to the cheek while you make sure the tube is properly positioned. Your patient should be able to speak.
Oh, sorry, that's fine, thank you.
You'll attach the distal end of the tube to the syringe. Aspirate gently to obtain gastric contents. You'll observe these are usually cloudy and greenish, but they could also be off-white, tan, bloody, or brown. Once you've verified the tube's placement, secure it with tape to the patient's nose. Clamp the end or connect it to a drainage bag or suction machine and fasten the end to the patient's gown. The head of the bed should stay at an elevation of 30 degrees to prevent reflux and to minimize irritation of the posterior pharynx. The patient should find the discomfort eases in a little while.
Okay, then the ideal position of the tip of the tube should be within the stomach, of course, after the level of the gastroesophageal junction, and the side port of the tube should be located in the stomach accurately, not in the esophagus. And sometimes we use nasogastric tubes with a small bore that can be used in the second part of the duodenum for feeding, and the position in the gastric antrum or other portion of the duodenum are also acceptable. Then here you can see the patient with two tubes. The endotracheal tube is selectively pointing to the right mainstem bronchus. The nasogastric tube is not actually reaching the stomach. This is the tip of the nasogastric tube, which is approximately in the gastroesophageal junction. Sometimes if you introduce too much of the tube, it will cause some loop in the stomach and go back into the esophagus. And this can be corrected by withdrawal of some of the tube lengths. Then you got the end in the stomach. And if the patient had the hiatus hernia, can introduce a very good length of the tube, and the tube is curling or looping inside the hiatus hernia, actually not reaching the stomach. Then a lot of complications can happen from the nasogastric tubes. Number one is incomplete insertion and the tube coiling in the esophagus, and the tube misplacement may occur, which is very dangerous, into the tracheobronchial tree, and infusion of feeding or medication is hazardous, of course. It will result in aspiration pneumonia and abscess formation or empyema or so on. Then the tube may be inserted in deeply into the bronchus so that it can affect the lung parenchyma by laceration, contusion. It may reach the pleural space, resulting in pneumothorax or hydropneumothorax. And I will show you some of these examples. Then here you see this is the endotracheal tube, which has looped inside the esophagus. It is not reaching the stomach. And this is an nasogastric tube that has been passed through the trachea into the right lower lobe bronchus. And this is another example of the tube which is located in the right main bronchus with injection of some medication that has resulted in this aspiration pneumonia, and this is the correct position of the tube. This nasogastric tube has been passed into the trachea and then to the left main bronchus. And this tube has passed through the trachea, left main bronchus, lower lobe bronchus, reaching the costophrenic angle, and the tube was quickly withdrawn after this chest X-ray. However, the patient developed a large pneumothorax, which required a chest drain. Then also, if the tube is located in the pharynx, in the esophagus, it may result in pharyngeal or esophageal or gastric perforation. These complications are, of course, rare. Radiographic findings of esophageal perforation, which is a hazardous complication, extra esophageal location of the tube. And if you inject food or medications, there is rapid development of pleural effusion, hydropneumothorax, mediastinal widening, pneumomediastinum, or mediastinal air fluid levels. Then we came to the, let's say, the fourth or the fifth line or tube, and this is the central venous catheters or the central venous line. You know that the central venous line is usually introduced into the superior vena cava, either from the internal jugular vein or the subclavian vein, from the left side or from the right side. The optimal position of the central venous catheter is in the lower part of the superior vena cava. Then this central venous line is usually used to introduce medication and to measure the central venous pressure and so on, and usually placed via the subclavian, internal jugular, or less frequently through the femoral veins. The central venous line should be located in the superior vena cava below the anterior part of the first rib. This is an optimal location of the central venous line. Then this is a video to show you how can you insert the central venous line.
To demonstrate the landmark-based technique for central venous line placement, we're using the equipment in this central line kit and suture tray, and our patient is a simulation mannequin. We prepare the skin surface by wiping with antiseptic, circling outwards once, twice, and a third time. Our patient should be in Trendelenburg position with head turned slightly to the left. And we apply sterile drapes around the field. You'll be relying on physical landmarks to properly position the line. The clavicle and the medial and lateral heads of the sternocleidomastoid muscle form a triangle. Our entry point is at the apex of this triangle. Other important structures include the external jugular vein and the carotid pulse. This is the catheter. Note the centimeter markings. Gently palpate the carotid and insert the finder needle in the point of the triangle, advancing slowly and staying lateral to the carotid. The trickle of blood shows we're in the jugular. You'll withdraw the needle, mentally noting the location and the angle of entry, and re-enter with the Seldinger needle. Hold the needle securely, remove the syringe, and start feeding the wire. That 20 centimeter mark disappears into the needle and we'll go just past that point. You see the wire exposed. Hold the wire as you carefully remove the needle. And at this point, we'll take the 11 blade with the sharp edge up to make a small incision where the wire enters the skin. This will facilitate the passage of the catheter. Before we begin, we palpate that sternal notch. Lay the catheter tip at the sternal angle with the other end to the needle entry point, and we can see the catheter is the right fit for this patient. We advance the dilator over the wire, advancing carefully to dilate the soft tissue, still holding the end of that wire with one hand. Now we advance the central line catheter over the wire, partly withdrawing the wire if necessary, until the wire is seen at the catheter hub. Uncapping that hub, we'll advance the wire backwards. Till it exits the port. Grab it and advance the catheter through the skin. Then remove the wire, getting ready to cap the port with your finger and put the hub back on. Now, an important check. Put a syringe containing saline in the hub and make sure you can both withdraw and infuse fluids. You'll check all hubs in this way before suturing and applying a sterile dressing.
Okay, this is the way how to insert the central venous line. It's better, according to the literature, is to have a chest radiograph after the insertion of the central venous line, and to assess its accurate position, and to also to show if there is any of the complications that will be mentioned in a moment. If the tip of the catheter has reached the right atrium, there is some risk of arrhythmia, some risk of myocardial perforation or cardiac tamponade. This is one of the policies you may, if you have some facilities in the X-ray, for example, is to inject some of the contrast material through the catheter to ensure its accurate position. And these are frequent sites of malposition of the catheter, including that the catheter has passed into the right side of the heart, into the azygos vein, into the internal jugular vein, as you can see in this example, into the internal mammary vein, the superior intercostal, the thymic, the inferior thyroid, or the subclavian artery. And these malpositions are seen in about 40% of the central venous line insertions. One of the major advantages of ultrasound is that it can guide the insertion of the central venous line accurately, and you are sure.
A linear array transducer with a venous exam type is used to perform an ultrasound-guided insertion of an internal jugular catheter via a transverse approach. The patient is in a supine position with the head slightly turned toward the contralateral side. The operator is positioned at the head of the bed. The transducer is placed transversely just below the apex of the sternocleidomastoid muscle triangle, with the orientation marker directed to the patient's left at a 9 o'clock position. The most superficial structure identified in the ultrasound image is the sternocleidomastoid muscle. Deeper to this, the internal jugular vein will appear as a dark anechoic elliptical shape and is compressible with transducer pressure. The artery will be circular and pulsatile. The thyroid gland lies medial to these structures and has a light gray echo signature. Adjust the transducer so it is centered over the internal jugular vein. Follow the needle entry by slowly sliding the transducer in the direction of needle advancement. The needle will appear as a small, bright, hyperechoic dot. When the needle tip appears, The transducer should be advanced a short distance distally to follow the tip of the needle trajectory and stay in advance of the needle entry. The needle is slowly advanced under direct ultrasound visualization until the tip is seen to indent and then puncture the internal jugular vein. The transducer should be moved slightly proximally and distally to confirm that the needle tip lies in the mid-portion of the jugular vein.
Yes, and this is one of the commonly used techniques nowadays to avoid too many complications of central venous catheter insertion. And here you can see this is the central venous catheter, which has been passed into the internal jugular vein, and this is the correction of the position of the catheter after that. And this catheter has been passed into the this venous drainage into the this patient happened to have a pulmonary venous an anomalous pulmonary venous drainage, where instead of the catheter it should cross the bead line through the innominate vein into the superior vena cava. It is located to the left of the midline, and this is one of the rare conditions that the patient had an anomalous venous drainage that, included the catheter. And in this particular patient, it happened to have a left-sided superior vena cava. And then if you introduce the catheter through the subclavian vein, it should go across the midline to the superior vena cava, but the catheter has reached into the right side of the heart because the patient had a left-sided superior vena cava. And this is an abnormally too high central venous catheter, which is seen at the level of the first rib, and this may result in many complications. Also, in this patient, you have an endotracheal tube selectively passing to the right bronchus with consequent opacification of the left hemithorax. Then the endotracheal tube is adjusted and the lung is aerated. Then you go to the central venous line, which is introduced through the left side but is not going across the midline to the opposite side. It has selectively passed into the left internal mammary vein. And this is the central venous catheter that goes into the subclavian vein back to the axillary vein. And this is a wrong or selectively mistaken left subclavian artery. You put the catheter through let us say this is the subclavian artery, and the catheter goes down to the axillary artery, which is confirmed by selective catheterization of the innominate or the subclavian artery through the femoral approach. Then also one of the frequent complications is the pneumothorax, and many times you may injure by the tip of the needle the apex of the lung, resulting in pneumothorax, which is occurring in about 5% of the cases. And this is one of the important guidelines is to have a chest X-ray after any attempt to introduce the central venous line, whether this attempt is successful or not. And vascular perforation is another life-threatening complication, which will result in bleeding. And the radiographic findings that indicate vascular injury: number one, unusual trajectory of the catheter. The course is abnormal. An apical cap due to extrapleural hematoma, apical opacity over the lung apex. A new pleural effusion that was not previously present due to the presence of hemorrhage in the pleural space. Mediastinal widening due to mediastinal hematoma. Knotting, looping, or kinking of the catheter may occur. And this is, as I have mentioned, one of the frequent complications of central venous catheter introduction is the pneumothorax. And this is also a central venous line that has introduced correctly into the subclavian vein and to the innominate, to the superior vena cava, and there is a large amount of pneumothorax. And this is the chest tube drained the pneumothorax with adequate aeration of the lung. Then if you put the central venous line inside the carotid artery instead of the internal jugular vein, and if you pass the catheter, it instead of going into the superior vena cava, it will cross the midline through the arch of the aorta, as you can see in this appearance. And also complication which is well known is the venous thrombosis due to prolonged catheter placement or multiple catheter insertions, especially in the superior vena cava, and this is one of the well-known complications nowadays. Venous thrombosis may result in pulmonary embolism. The catheter may fragment in approximately about 1% of the cases with a distal embolization of the catheter fragment. The catheter may be compressed between the first rib and the clavicle. Migration of the fragmented catheter may result in arrhythmia, vascular injury, pulmonary embolism, and very rarely death. This is the superior vena cava thrombosis, and this is the central venous line catheter. You can see non-opacification of the superior vena cava due to the presence of clotted blood. This diagnosis is only reached either by ultrasound or by CT scan. Then catheter fragmentation. This is the central venous line, and this is a fragment that has migrated into the right ventricle. And this is also catheter fragmentation, and you can see the fragment in the right ventricle as well. Now we came to the Swan-Ganz catheter, which is a pulmonary artery catheter, and this is used for measuring the pulmonary capillary wedge pressure and to monitor the circulatory hemodynamics. In some cases, it can help to differentiate cardiogenic from non-cardiogenic pulmonary edema. The Swan-Ganz catheter is a long catheter that is inserted intravenously, aiming at the pulmonary artery, and the tip of the catheter should not extend beyond 2 centimeters from the hilum. Then the catheter has a balloon at its tip and is inflated only when measurements are being obtained. An occlusion of the pulmonary artery branch can result by this inflated balloon can result in pulmonary infarction. If the catheter is pushed too distal, if there is persistent inflation of the balloon, if a clot is forming around the tip of the catheter, then have a look about this Swan-Ganz catheter.
Now I'd like to cover the pulmonary artery catheter here a little bit. Basically, the distal tip of this pulmonary artery catheter is designed to sit in the pulmonary artery so it can actually measure pulmonary artery pressure. In order to get this into a pulmonary artery, you have to start a central line with a central catheter that has an introducer port, and then you're going to insert the swan through the introducer port and guide it into the pulmonary artery. So the first question you're probably going to have is how does this actually get into the pulmonary artery, and what prevents this from coiling up like this in someone's atria or ventricle? And the answer is this balloon on the distal tip that I'm going to inflate here. This balloon acts kind of like a sail on a sailboat, because when this balloon is inflated, it follows the direction of the blood flow. And so assuming that this catheter is not coiling up, The blood flow should guide this from the right atrium into the right ventricle and into the pulmonary artery. The second question that you may have is, how are you going to know whether this is truly in the pulmonary artery or whether it's coiled up? In other words, how do you know how far to advance this before stopping? And the answer there is that before starting, you simply just will hook up your Swan-Ganz catheter up here to a transducer tubing, and then you're going to have to watch how the waveform changes as the swan is guided through the heart. Because the right atrium, the right ventricle, and the pulmonary artery each have a distinct waveform. So if you keep advancing this and all you see is a right ventricular waveform, you're most likely coiled up, and so you're going to need to deflate the balloon and pull back and try again. One thin black line there means 10 centimeters. So there's 10 centimeters, 20, 30, 40, and then a thick black line there means 50 centimeters. And it goes all the way actually up to 100 centimeters. The balloon port is this red port. And so if you want to inflate the balloon, you just connect your syringe to this red port and inflate. The yellow port is always called the PA distal port. And what this means is this lumen here goes all the way to the distal tip of this catheter. The connection to this yellow port is you're going to connect transducer tubing, and the purpose of that is you're going to use that to monitor pulmonary artery pressure and wedge pressure. Now let's go to this blue port here. The lumen to this blue port is much more proximal than the distal lumen, so I can demonstrate this by connecting saline here. And if you follow it all the way over here, you're going to notice that saline comes out of that port right there. We connect transducer tubing to this blue port here, and we use that to monitor central venous pressure. The last port that I want to cover here is this clear port, and sometimes it's a white port. And this lumen is also proximal to the distal tip of the catheter, and it is roughly next to the CVP lumen. The purpose of the clear lumen, or the white lumen here, is for the connection of all of your cardiac infusion drugs. The last thing that I want to cover on this pulmonary artery catheter is this sterile contamination shield here. And sometimes it's pre-built onto the swan, but sometimes you actually have to put it on yourself. But basically, once the swan is in the right place, you bring this contamination shield all the way down to the hub of the cordis and attach, and that allows the portion of the pulmonary artery catheter that is hanging outside of the patient to remain sterile.
Okay, then you have an idea about the Swan-Ganz catheter, and this is the accurate position of the catheter as shown in this frontal chest radiograph. You see, this is the catheter introduced through the internal jugular vein and through the superior vena cava, then to the right atrium, to the right ventricle, to the pulmonary artery, and selectively into the right one. And this is the tip of the catheter, which, as I have mentioned, should not be far away from the hilum. It should be within 2 centimeters from the hilum itself. And you see here, this is the Swan-Ganz catheter introduced through the internal jugular vein on the left side, through the innominate vein to the superior vena cava, to the right atrium, right ventricle, and to the right pulmonary artery. This may show to you how to insert the catheter. I'm sorry that this video is not working. Okay. I'm sorry for this.